Okay, so this is my recording for lecture this past Thursday, the October 1st. It didn't record Thursday when I was in class, so I'm doing it a little bit late. Anyways, we're going to learn about fetal assessment, and usually fetal assessment in terms of what the tests we're going to be doing usually begin about 28 weeks. Depending on what test you're doing, between 28 and 32 weeks, babies are mature enough to do the things we're asking them to do. And one of the things that we ask them to do is fetal movement. We track fetal movement, and if a patient is feeling less than 10 movements in a 3-hour period, then they're to call the office. And then the office will usually ask them to do a fetal kick count, which is 4 to 10 movements in an hour. So we tell them to go get themselves something to eat or drink, and sit down in a quiet, dark room, no TV, no radio, and concentrate on baby movements. And after that hour, if they're not feeling those movements, then they need to call the office. And then come in for monitoring at the hospital. Most of the time, hopefully, the woman's just been busy and hasn't noticed her baby move, and everything's okay. Babies do have sleep cycles, so that's why we give it a whole hour, to feel the movements. We ask mom to eat and drink in case she's a little dehydrated or a little low on sugar, and to go and be quiet and be calm and just concentrate on baby. Okay. The other tests we can do on babies are ultrasounds. Of course, we can do the abdominal and the vaginal, starting at 6 weeks, determining gestational age. We can look at fetal heart rate, fetal movements, breathing movements. We can do measurements on the baby to estimate gestational age and screen for some anomalies, heart defects. We can measure the amniotic fluid level, locate the placenta, look at the placenta and to see if it's healthy, and determine baby's position if we're getting close to delivery date. The other study that we do that we don't do often, it's not a regular study, it's a study that is ordered when the physician is worried about baby's nutrient and oxygen exchange through the placenta. Maybe we've got some fetal growth restriction or something like that. And we look at the blood flow through the placenta. Okay, so we get the systolic measurement, which is the highest highest point on this waveform that they're seeing from the blood flow, and then the diastolic, which is the lowest point. It's a ratio that they determine, and about 20 weeks, of course, the result is 2, and then less than 3 after 30 weeks. You don't need to know these values. Just know that about a Doppler flow, that it is something that they look at to determine blood flow through the placenta, and then are able to determine if baby's getting adequate nutrients and oxygen. The most common one we do is the non-stress test. These can be done in the clinic, or a lot of times the clinic will send the patient to the hospital. It's an evaluation of fetal oxygenation status, and it does require an electronic fetal monitor. So if the clinic has one of those, that's great. If not, they send them to the hospital. Now, in a non-stress test, we are looking for 2 accelerations in a 20-minute period that are 15 beats above the baseline for at least 15 seconds. And then that's for a term baby. If the baby is preterm, then we will accept 10 beats above the baseline for 10 seconds. It's still in the 20-minute period. Now, excuse me, we can start this test at 28 weeks. Now, it says 50% of babies 28 to 32 weeks. So, 28 to 32 weeks is just a range when we feel that the baby is mature enough, the baby's central nervous system is mature enough to react the way we want it to react to fetal movement. So if your baby comes in at 28 weeks and is not able to pass this test, either their central nervous system development is not ready yet, or something's wrong with the baby. So you will need to do further testing to just determine fetal well-being, okay? It doesn't necessarily mean that something's wrong with the baby. It just might mean that the baby is not mature enough to do the test. So there's a window there of that questionable maturity, and that's 28 to 32 weeks. However, if the baby does come in at 28 weeks and pass this test, then if they come in again at 30 weeks, they need to be able to pass the test. There's no going backwards as far as not being mature enough. So if they come in at 28 weeks and they pass it, and then they come in at 30 weeks and they do not pass it, then we know that something's wrong, okay? So once they pass it, they will always pass it unless something's wrong. And here is a picture of a reactive non-stress test. Now, either the babies pass or fail this test, and we don't say pass or fail. We say they are reactive or non-reactive. And the official correct terminology is if they pass this test, then they have a reactive non-stress test. Reactive is a positive word. Non is also a positive word. They're not stressed. So they're positively not stressed. That's what reactive non-stress test means. They are positively not stressed. This baby is not stressed. Now, if you have a non-reactive non-stress test, then non-reactive is negative, okay? And so they're negatively not stressed. Does that make sense? So they are stressed. I know that's kind of confusing, but try to think of it in those terms. They're negatively not non-stressed, okay? So they are stressed. So if they do not pass the test, it's a non-reactive non-stress test. If they do pass the test, it's a reactive non-stress test, okay? So you'll also hear it said abbreviated, this baby is reactive. That means this baby is good. It has good accelerations. Or you'll hear this baby is non-reactive. That means that the baby is not good, okay? The other test is the contraction stress test. Places don't do this much anymore because of another test that I will tell you about in a few minutes. But a contraction stress test is a test where we need to evaluate the baby in relation to contractions. It tells us uteroplacental efficiency, whether we have it or not, okay? And we can tell if this baby is struggling, is having oxygenation problems in utero, okay? So with a contraction stress test, we need to have contractions in order to do the test. So for people that have these contraindications, you will absolutely not do a contraction stress test. You do not want these people to have contractions. And you can see here, this is pretty evident that someone who has bleeding from a placenta previa, which we'll talk about later, you do not want them to contract. A person that has an abruption, a placental abruption, you do not want them to contract. A person who's had a classic cesarean section incision, that's a vertical incision straight down through the entire uterus, those people are not able to do vag deliveries, okay? Only the C-sections that have the low transverse horizontal incision are they allowed to attempt a vaginal delivery after that C-section. So a classical C-section, no contractions. Premature rupture of membranes, no contractions. All these things, we do not want these people to be contracting, okay? So when we do a contraction stress test, we do need contractions. So she can either be contracting spontaneously, which rarely occurs when you want to do this test, or we have to induce contractions in some way, shape, or form. And the way we do that is we start Pitocin on these women, or we have these women do breast stimulation to induce contractions. Now we're looking for 3 contractions in a 10-minute period that are at least 40 to 60 seconds. When we get those contractions, we stop the Pitocin, we stop the breast stimulation, whatever we're doing. Once we get 3 contractions in 10 minutes, then we evaluate the fetal heart rate in response to those contractions. Now, if we have those 3 contractions in a 10-minute period and no late decelerations, then the baby has passed the test. In other words, the baby has a negative contraction stress test. Negative meaning they are not having stress with contractions, so that's great. We don't want babies to be stressed with contractions. This is a baby who has a positive contraction stress test. They are positively having stress with contractions. This is not good. You can see that baby is having late decelerations with every contraction. So that's not good, okay? An equivocal test, so babies don't either, they don't do either one or the other. They might do a little bit of both. So that means they might have a few late decelerations, or they might have some significant variable decelerations. Now you remember variable decelerations are cord compression, but when you're having them with every contraction every 2 minutes, you're having, they're lasting 60 seconds, they're dropping way down to 60s or below 90. Those are significant. That baby is having an insult every 2 minutes. Even though variable decels are a normal reaction to cord compression, this baby is going to get tired. So anyways, if you're having these, your baby definitely is not passing the test. Your baby is not failing the test, but your baby is on the fence, like you don't know which way this baby is going to go. So the test is equivocal, meaning you will need to do more testing, okay? Or meaning that this baby is on the way to being severely compromised, and you might have to sit on this baby for a while. So anyways, a negative contraction stress test, it means that they're negatively stressed when they're having contractions. They're not stressed when they're having contractions. So we're having normal placental function, we have an oxygenated baby, and our baby can probably tolerate the stress of labor. And then as opposed to the positive contraction stress test, baby is positively stressed when they're having contractions. This is a baby who will not withstand labor, who is having fetal compromise already. Okay, and we're not even laboring. We just help this woman have a few contractions. So this baby is not going to do well. Okay, now I said that places are not doing the contraction stress test very often because there's another test they can do, and the other test is the biophysical profile. It's non-invasive. The contraction stress test, they have to be in the hospital. They have to have an IV. We'll probably be running Pitocin. So we're having to do a lot of things to this patient, whereas the biophysical profile is non-invasive. The first part of the test is they get a non-stress test. That's part of the biophysical profile. Now, if we've done a non-stress test and the patient is non-reactive, in other words, the baby failed the test, then we will go on and complete the biophysical profile. But even if the baby has a reactive non-stress test, meaning they passed their non-stress test, some physicians will want the rest of this biophysical profile completed, okay? And the rest of the biophysical profile is an ultrasound where they're looking for fetal movement, fetal breathing movements, fetal tone, and amniotic fluid level. When they're looking for fetal breathing movements, babies are not breathing in utero like they would after they are born, but they do have breathing movements that the ultrasonographer can see. And then, of course, we want to see the baby moving, kicking, and all that kind of stuff. Fetal tone is the baby laying in there like they were a Raggedy Ann doll, or is the baby nice and flexed with the arms drawn in and the legs drawn up to their belly, okay? Those are things we want to see. Now, when we score this, they get 2 points for each one of these variables. So the 4 ultrasound variables and the variable for the non-stress test. Did they pass it? Yes or no? If they passed each one of these criteria, they get a score of 2 points for each of the criteria. If they do not pass the criteria, they get a 0. So we have 5 criterias here. The non-stress test is 1, the 4 ultrasound criterias, so that's a total of 5. So 2 points each. They could get a total of 10 on this test. And if they get a total of 10, they're really great. The baby is really great. You can send this baby home. They can even get an 8 on this test, and we can still feel comfortable with this baby. However, if this baby scores a 6, depending on your facility, they'll probably admit this patient for continuous observation and try to keep this patient pregnant as long as they can. So if we're doing constant surveillance on the mother and the baby, then we will be minute by minute up to date on how well this baby is doing. So we might be able to sit on this baby for days or weeks. Now, if this baby scores below 6, then they're probably going to get induced or get a C-section, depending on what the circumstances are with this baby. So the biophysical profile helps us determine fetal well-being and placental efficiency. Okay, they get a score of 2 for each criteria they pass. They get a score for 0 for each criteria they fail, a maximum score of 10. Okay. Now we're moving on to amniocentesis. There's several tests we can do with an amniocentesis. An amniocentesis is when they go in with a needle in through the mom's abdomen into the uterus and withdraw amniotic fluid. They do this test under ultrasound guidance, and the risks for this test are infection, bleeding, spontaneous rupture of membranes, preterm labor, penetrating the placenta, which we don't want to be doing, or hitting the baby, which we don't want to be doing. But those 2 things are unlikely because we're doing it with ultrasound guidance. Anyways, one of the tests we can do with amniotic fluid is fetal lung maturity. Now, there's several different tests for fetal lung maturity. This test is called the lecithin sphingomyelin test. It's an LS ratio. Okay, so they're comparing the L to the S. I'm sorry, I don't want to say these words. But anyways, these are components of surfactant. Surfactant is the product that the baby produces to help keep their alveoli open, okay? So they start producing this in early pregnancy. It increases towards 32 weeks. The sphingomyelin begins to drop, and the lecithin begins to increase, okay? And then by 35 weeks, the ratio between the L and the S should be 2 to 1, okay? And if we have 2 to 1, then we can say that we feel that our baby's lungs are probably mature, and that if this baby was born, that they would have a low risk for a respiratory problem. Now, we're saying at 2 to 1, we're probably mature and that our babies have a low risk. Okay, that does not mean if we have a 2 to 1 LS ratio that we're definitely going to have a perfect baby. Okay, we're just saying that our risk is low. Okay. Now, the other test that we can do besides the LS is this fluorescent polarization test. It measures the surfactant to albumin ratio. This is a quicker test. It's a cheaper test. If the result is above 50, then we're probably good for fetal lung maturity. They use a 55 for diabetic mothers just because of how diabetes affects the albumin ratio. Okay. Anyways, the other test we do is PG. If PG is present in the amniotic fluid, then we're saying that we may have lung maturity. If it's not present, we do not have lung maturity. Okay. And then the last test is the lamellar body count. If our lamellar body count is above 32,000, then we are saying that we probably have lung maturity. Now, with that being said, all these tests, we test fetal lung maturity for babies that we feel we need to induce before term. Now, there's a national standard of and protocol of not inducing women before 39 weeks unless there is a medical or obstetrical indication. And if there's a medical and obstetrical indication, we need to induce that woman, even if she's preterm. Now, if we do a fetal lung maturity and that tells us that we do not have mature fetal lungs, but we have an obstetrical or medical indication that we need to have this woman delivered, we're still going to deliver. Okay? The lung maturity result will just give us a heads up to let us know we need a NICU team there, or we need interventions for baby, which we're probably going to know anyway because we're delivering this baby preterm. So much of the time, physicians are not even doing fetal lung maturity tests on babies because if they have an indication for delivery, they're going to deliver irregardless. Okay, and with this national movement to not induce women before 39 weeks, they're not needing to do this fetal lung maturity. It's a moot point because they're following the protocol to not induce before 39 weeks. Therefore, they don't need the LS ratio or the lung maturity test. And then if they are doing it before 39 weeks, they have a medical or obstetrical indication. And if they are delivering preterm, they are going to be prepared with a NICU team for this baby. All right, so the other test we can do on amniotic fluid is the triple test or the quadruple test. These are tests to determine if there's any trisomy problems with babies. So do we have Downs, or do we have trisomy 21 or 18 or any of those other type of trisomies? They look for fetal lung maturity. They look for alpha-fetoprotein. They look at HCG measurements. They look at unconjugated estriol. And these tests, if these items are present, then they will indicate possible Down syndrome. The quadruple test is also performed. Can be another test, and I think they're usually going towards just the quadruple screen as opposed to the triple screen, and they will screen for trisomies, and they will also screen for neurotube defects. Okay. Those are done, you know, in the early second trimester. This chorionic villus sampling can be done in the first trimester, very early in pregnancy. If you remember about the chorionic villi on the placenta that attaches to the uterus, they're getting a sample of that, and they can do DNA studies. They can obtain this either abdominally or cervically, going in through the cervix. There are risks for these, bleeding, rupture of membranes, preterm labor, or spontaneous abortion. They can even injure the baby, sever some baby parts. Now, this is done in the first trimester usually, and so this fetus is very small. Everything is very small, so the chances of doing something wrong to the baby is risky. Now, both of these tests, the chorionic villus sampling and the quad screen, these are done for for people that are trying to look for neurotube or trisomy problems, and the patient may opt for an elective abortion if the babies appear to have some sort of problem. These tests are offered to women who are at high risk, okay? These women can opt to have this test, or they can decide not to and just follow through with the pregnancy and deal with any issues that their baby has at delivery. So here are your risk factors, and there you go for that. So the next thing that we're going to cover, now if you have any more questions about 14 besides what I went over, again, I don't go over every single thing in the chapter, I just go over some major points. Please email me and let me know. Now, chapter 21, we're going to talk about risk factors for preterm labor complications, okay? So I put up these signs and symptoms of preterm labor because most of them, besides the rupture of membranes, are pretty, they can be very mild symptoms, and they could be, and that could indicate preterm labor, so you want to intervene for your patient. But a lot of pregnant women have these complaints all throughout pregnancy, and they're not in preterm labor. So I say that to caution you, do not dismiss any woman who is complaining about these things. Okay, you really need to do your investigation and your assessment. Preterm labor is labor that occurs between 20 and 37 weeks. If it happens before 20 weeks, then she may be aborting, okay? And usually they're having uterine contractions at least 4 in 20 minutes. Actually, if she's having 4 in 20 minutes, I caution my women, if they have 4 contractions in an hour, I need to be informed. They need to call. It could be, just Braxton Hicks, but we want to definitely be on top of things. So your book defines preterm labor as 4 in 20 minutes or 8 in an hour. And they have cervical change, a change of greater than 80%, okay? Now, we will use medications to try to stop their labor. We can use tributaline or breathine, which is an asthma medication, and it's not FDA approved for preterm labor, but the mechanism of action of breathine affects the uterus as well and quiets the uterus. So we can sometimes use that. We can use Vistaril, morphine, Phenergan, anything that relaxes the mom, relaxes the uterus, and may help stop preterm labor contractions. Some women are put on labetalol to stop contractions. Hydralazine, mag sulfate. So depending on the physician's orders, basically, is which drug you're going to use. Okay. Now, I put this on here because you will see or hear PPROM or PROM. They are two different things. Okay. So spontaneous rupture of membranes before the onset of labor is called PROM. Okay. Premature rupture of membranes. So their water broke and they're not contracting, they're not in labor. That's premature rupture of membranes. If they have PPROM, they have preterm premature rupture of membranes. So it's a differentiation between whether she ruptures in a preterm state before 37 weeks, then she's pre-prom. If she's PPROM or preterm premature rupture of membranes, if she ruptures after 37 weeks with no contractions, then she's just PROM, premature rupture of membranes. Okay, so if that wasn't confusing, I don't know what is. But this is just a determination of when they rupture, no contractions. Is it before 37 weeks or after? Okay. Now let's talk about placental previa. This is a bleeding issue for mom. Placenta previa is when the placenta is attached low to the cervix. There's different degrees, okay, and this can cause a bleeding for mom, okay. So she either has a total previa, a partial previa, a marginal, or a low lying, okay. So a low lying, the placenta is low in the uterus. It's close to the cervix. This woman could have some bleeding issues, but she could probably have a vaginal delivery. The problem that we're talking about with vaginal deliveries and a previa is if that previa is too close to the cervix or covering the cervix, then laboring contractions in the baby's head on the placenta is going to cause severe bleeding issues, okay? And we don't want that. So a low-lying placenta, as you can see, the placenta is low, it's close to the cervix, but this person can probably have a vaginal delivery. Now, this is a partial previa, and I don't have a picture of a marginal previa, but a marginal previa is at the border of the cervix. And from this picture, this looks like a marginal previa. However, they're calling it a partial previa. So the placenta is partially covering the cervix. That's the difference. A marginal is touching, a partial is partially covering the cervix. So this person would not be having a vag delivery, okay? She would have to have a cesarean section. And then here is your complete previa. The placenta is completely covering the cervix. So she cannot have a vaginal delivery. Now these women have bleeding issues, and if the bleeding issues are severe, if we can't get the bleeding issues to stop, then she will need to be delivered, okay? Now here's another bleeding issue for moms. This is an abruptio placentae. She has, her placenta has separated from the uterus, and there's different degrees of this as well, okay. There's a marginal abruption, there is a concealed or central abruption, and then there is a complete. With a marginal abruption, let's see, I think, okay, so here's a marginal abruption. Most of the placenta is still attached to the uterus, but there is a small section that has broken away and that is bleeding, Okay, so hopefully we can get that bleeding to stop, and then this pregnancy can continue. If she has a central or concealed abruption, then the outer edges of the placenta are still adhered to the uterus, but the center of the placenta has broken away, and she's bleeding under the placenta. She's bleeding between the placenta and the uterus. Let me see if my slide says this. So the bleeding is trapped, but the bleeding can force its way into the myometrium and cause a huge problem within the myometrium. And then we have the complete abruption, and the placenta has totally broken away from the uterus. This woman is bleeding, and we need to get this baby delivered. Cervical insufficiency or incompetent cervix. This is when the cervix dilates without contractions, without pain. The woman is totally unaware that this is going on. Okay, so she shows up for a normal prenatal visit, and this is detected on a visit. Here are your risk factors for her developing a cervical insufficiency. We put these women on bed rest. We could put these women on bed rest, antibiotics, anti-inflammatory drugs, progesterone, to keep her from contracting or dilating. And then we normally just do a cerclage. A cerclage is a surgical procedure where we stitch the cervix closed. We keep that in place until she's about 37 weeks, and then we cut the stitch and possibly send her home. She may remain pregnant for a couple of weeks, or she may right away go into labor and deliver. So, okay, now we're talking about problems with the amniotic fluid prenatally before she ever goes into labor. She has hydramnios, or she has oligohydramnios. Hydramnios, which a lot of people call polyhydramnios, is too much fluid, and oligohydramnios is too little fluid. Okay. Risk factors for developing hydramnios is the mother has diabetes, there's an RH sensitization, infections, or there's fetal anomalies, malformations. Okay. We do an amniocentesis to pull off fluid. We had a patient admitted at CMC several months ago, and she had severe hydramnios, and she went, I never took care of her, so I'm not sure how often she went up to the perinatologist's office, or how often he came down, did an amniocentesis to pull off fluid. We pulled liters off this woman. It was phenomenal. And I didn't follow her at delivery or postpartum, so I'm not really sure. Sorry, it's a story without an end. I don't really know what was going on with the baby. But anyways, babies are probably have some sort of problem, which is contributing to an increased production of amniotic fluid. Then you have the baby with oligohydramnios. We have usually have a fetal growth restriction, or we have some sort of fetal and renal problem where not enough amniotic fluid is being produced. Okay, here are some more possible fetal complications. And cord compression is a big, huge issue with low amniotic fluid. If you remember when I talked about variable decels occur when there's cord compression. So if you're having contractions and your water's broke and there's not a lot of fluid in there, you might see some cord compression or variable decels. However, you can not be contracting, you cannot be in labor, and you can still have an intact bag of waters but you're having cord compression because you don't have a lot of amniotic fluid in there to cushion the fetus and the umbilical cord. Okay. So anyways, those are your problems for baby. Now we do biophysical profiles and NSTs. We do serial ultrasounds to keep track of amniotic fluid level, and we possibly may need to induce this baby depending on the severity of the oligohydramnios. One of the things that we do for oligohydramnios is an amnio infusion. That's when we put normal saline back into the uterus. So that could possibly help cushion that cord. Of course, we're going to be doing continuous monitoring and turning our mom to relieve those variable decels. Remember, positioning, we can try to maybe see if we can shift things around so that there's not pressure on that cord. Okay. And then, of course, once the baby is born, they'll be doing tests to see if baby has any problems. All right, so moving on to Chapter 22. Let me know, again, email me or call me or come to my office if you have any questions about Chapter 21. So now we're going to talk about labor complications. Okay, so one of the big one big problem is post-date. So we don't want babies born premature, but we also don't want babies born post-term. If we have post-term babies, then we might have problems with induction. We might have problems with our labor function. We might have a large baby and have dystocia problems with delivery of baby. And we might need to use forceps or vacuum to help deliver the baby, which puts both baby and mom at risk. And mom could probably have infections, trauma to her perineal area because of this large baby or the use of instruments for delivery. We are at risk for a cesarean birth. Hemorrhage. Why are we at risk for hemorrhage? That's because this uterus is extremely distended from this large baby, or this uterus has been overworked by a dysfunctional labor and the use of Pitocin, and it does not want to contract post-delivery. So mom has bleeding issues. All right, here are the risk factors for having a post-delivery. So the placenta only lives so long, and the more post-term the baby gets, the more the placenta is deteriorating, and therefore the placental efficiency and perfusion to baby has been diminished as well. Okay, so here's all these risk factors. Okay, orthopedic and neurologic injury. Mom can have a orthopedic injury with delivery of a very large baby. Her symphysis pubis can be separated. Her coccyx can be broken. But we're talking mainly about orthopedic and neurologic injury to the baby. So did we break a clavicle? Did we have a Erb's palsy plexus injury? Did we mold the head so much, this large head and this normal pelvis, did we mold it so much that we did injury to the brain? Okay, and did baby have enough asphyxia to develop cerebral palsy? So all these things go into play. Now, we talked a few weeks ago about positioning. We talked about the occiput anterior position, left or right, being the most normal positions to deliver in, and that the occiput posterior position was a difficult position. That's when baby is sunny side up or facing up. The occiput is to the posterior of the woman. This is a this baby, this position can be delivered vaginally. However, mom does need to push harder. But we also have face, brow, a head or a military position, a chin presentation, a shoulder presentation, which is your transverse positioning or transverse lie, and then the breech babies. So this is the occiput position that we want baby delivered in, okay? That lowest part or the smallest part of the head is coming through the birth canal first. That's the smallest diameter, so that's the best positioning to be in, okay, for delivery. But we have this brow presentation, and here is the reasons why we sometimes end up with a brow presentation, okay? Baby, for some reason, does not come down with the occiput first. They come down with the brow of their head first, okay? It could cause a longer labor because, or a dysfunctional labor pattern, and a cesarean birth with a brow presentation is probably going to occur. If the baby is large, or even if the baby is normal weight, depending on the size of this woman's pelvis, that brow presentation has a huge diameter, and so the passage through the birth canal might not be able to occur. Okay, so she might need a C-section delivery. If the baby is delivered with a brow presentation, we could do severe damage to the cervical spine, the neck, the trachea. We could do a lot of facial damage, and this could be a problem for baby, okay? So we will see all these things, the caput, facial edema, contraindications, a manual version. It says conversion, but we're putting forceps or a vacuum in to try to get this baby delivered. We don't want to be throwing oxytocin on this type of presentation, and you will definitely not put a scalp electrode on a baby's brow, okay? A scalp electrode is reserved for the actual top of the head, okay? And this is what it looks like as far as the diameter. That's a huge diameter. You see it says 13.5 centimeters. The occiput diameter is 9.5. Okay, so that's huge. 4 whole centimeters is huge. Okay. And then this is the military position. This is like the top of the head coming down. That is another big diameter. It's possible this can be delivered vaginally depending on the size of this diameter and the size of the mom's pelvis. However, this is going to be hugely difficult, okay? So maybe the physician can help tuck that baby's head a little bit. A face presentation is similar to a brow, but you've got eyes, nose, and mouth presenting. And this causes, again, like similar to the brow presentation, it causes a huge hyperextension of the baby's neck. So here are your risks, very similar to brow presentation. Here are what we're going to do to the baby if we are successful in delivering this baby vaginally. I mean, these are possibilities, okay? These are risks, okay? So with the face presentation, you might be able to do a vaginal birth. However, you do have those risk factors. So depending on the size of that diameter, whether we can do that. If the mentum remains posterior, that's the chin. So I will show you a picture of why you can't deliver this, or reduce or reposition that head to get it delivered if the mentum is posterior. Okay, so if the chin is to the back of mom, this is going to cause her to need a C-section. Okay. So here is the face presentation. Look at the extension in that neck. Look at the trauma. You can just see the trauma that you're going to do to that baby's neck. Okay. Here is what you would feel on vag exam, similar to a brow presentation. So here is a picture of a face presentation being delivered. You see the chin in this picture is anterior. Okay, so we will be able to tuck that chin and round that baby's chin and neck around her symphysis pubis and deliver that baby. Okay, as opposed, oh my gosh, this just looks horrible. There's no way to tuck this, the chin, that skull is in the way. It's banging against that pubic bone. There is no way to tuck this and deliver this vaginally. Okay, this just ain't gonna happen. I just want to move on. That was horrible looking. Okay, so a transverse lie is a shoulder presentation. Hopefully, if a baby is transverse, it is detected before the woman goes into labor, and then the physician will be able to do an external cephalic version. What that means, you'll hear it called external version or just a version. This is where the physician is turning the baby to be head down, and he's manipulating the baby from mom's abdomen. So that's external, as opposed to an internal, which I'll tell you about later on. Okay. So hopefully they're doing this before term. They want to do this before term because just of the size of a baby at term compared to the size of a baby at 36 or 37 weeks. Okay, and we want to do this before labor so that we're not fighting the forces of contractions trying to turn this baby. Okay. So here is what a transverse lie looks like, and here is what you feel on vag exam. Okay, you feel the shoulder. Let's see here. So here are some risk factors for a breech presentation. Breech presentations, we don't deliver vaginally because of the risk to the fetus for a spine injury, okay, or getting the head hung up in the cervix during a vag delivery. Okay, therefore, we're doing injury, we're having problem getting that head delivered after the body delivers vaginally. The head gets hung up and stuck, and the forces of labor and maybe the forces of the physician who's trying to help deliver this baby ends up damaging the spinal cord. Okay, so bad juju there. Here are some more implications for the baby with a breech presentation. So just like a transverse lie, we do want to try to attempt to turn this baby with an external cephalic version before term, so 36 or 37 weeks. So I mean, depending on the size of this baby, we could turn this baby anytime. However, the bigger the baby, the more close to term, the more difficult it's going to be. Okay, and then hopefully avoid a cesarean section. Now, here are your breech presentations. There's a couple of different kinds. This is a frank breech. A frank breech means that it's all baby butt. Okay. This is an incomplete breech or a footling breech. You'll hear more often a footling breech. You got one or both feet down there. Okay. Here is another picture. I just should have thrown this out. It's a frank breech, a complete breech. It's all baby butt. Okay. Anyways, so moving on now is the risks of having a large baby. So a large baby greater than 4,000 grams is called fetal macrosomy. This baby could possibly be delivered vaginally depending on the size of the woman. However, more often than not, you get a cephalopelvic disproportion. That means the baby's head is too big for the mom's birth canal, the pelvis. Okay, you have a dysfunctional labor and a prolonged labor. A dysfunctional labor because the baby is so big that the uterus's ability to contract has been hindered. And then if this baby is actually delivered vaginally, we could have a lot of trauma to her perineum. And then post-delivery, because that uterus has been so overstretched because of a large baby, because of maybe a prolonged labor, and a use of lots of Pitocin to get her delivered vaginally, you have a uterus that does not want to contract after delivery, and therefore you have hemorrhage. Okay, here are your risk factors for baby if delivered vaginally. A shoulder dystocia, which is a obstetrical emergency. The head has been delivered. Okay, the shoulder gets stuck behind the mom's symphysis pubis, her pubic bone. Okay, that's an obstetrical emergency. It requires nursing and or physician, it requires nursing and physician intervention. You will do McRoberts maneuver, which is basically you and the support person holding mom's legs back on the side and back towards her head as far as you can get them to help release this shoulder. The nurse will do super pubic pressure. She will not, I repeat, she will not do fundal pressure. She will do suprapubic pressure, which is she puts her fist suprapubically, she pushes down on that shoulder, and then according to what the physician says the baby is facing, then she also pushes towards that direction. So if the baby is facing left or right, the nurse will push down on the shoulder towards the left, basically trying to collapse the shoulders, to try to fold the shoulders so that they will fit through. Okay, we run the huge risk of a brachial plexus injury, fractured clavicle. We could have meconium aspiration, all these things for a baby, okay, with a macrosomy baby. So sometimes the physician will suggest or recommend that this woman has a cesarean delivery. So she can agree to doing that, or she can attempt a vaginal delivery, and with the knowledge that we may go to the C-section. All right, here is a very rare and a very deadly complication. It's called amniotic fluid embolism. That is the old name. They're currently calling it anaphylactoid syndrome of pregnancy. Like I said, it's very rare, but the mortality rate is super, super, super high. This is very bad stuff, okay? This occurs during labor and sometimes after birth. The question is some sort of reaction to amniotic fluid, okay? So that's what happens. This is what happens to mom. Sudden respiratory collapse, circulatory collapse, immediate delivery and resuscitation of mom is required. This happens fast, this happens sudden, and this is extreme, okay, guys? We need to support mom's cardiovascular respiratory status. We need to get this baby delivered, and then we need to help mom after delivery as well, okay? Hemorrhage, shock, death are going to occur if we cannot get this under control. And very well, we may do everything humanly possible, and we may do everything correct, and we still may lose mom with an amniotic fluid embolism, okay, guys? So this is really scary stuff. We had an incident within the past year at CMC. This patient was actually a birthing center patient. Her water broke at home. She went into labor. She went into the birth center within 10 minutes, within the shortest amount of time possible. Jeannie Hebel recognized that this patient was having amniotic fluid embolism as soon as she got to the birthing center. Immediately rushed her by ambulance to CMC. We immediately did a cesarean section. This baby was in NICU for a long, long time, and then it was determined after, I'm not really sure, it was several days or even several weeks, this baby was not going to make it. We had the mom here. I can't remember what all they did for this mom, but extraordinary efforts to save this mom. She was in ICU. We ended up, after a couple of days or so, we ended up shipping this mom to St. Pat's, Providence. They had her for a while. I don't remember how many days or how long they had her there, and I believe they ended up shipping her to Seattle. She was on dialysis. She was in liver failure. I think the mom, I'm pretty sure the mom recovered, or at least survived. Probably had, was going to have lifelong kidney and liver problems, and I don't know what else. So this is really bad stuff. This is the worst thing you'll probably ever see in OB. It's the scariest thing, and thank God it's probably the rarest thing you'll ever see. Okay, so your basics, airway, breathing, circulation, get her delivered, and then airway, circulation, breathing, and hemorrhage treatment. Okay. All right, so enough of that ugliness. Stages of labor, I'm not going through those all again. I do want to cover really quickly retained placenta, lacerations, and then talk about placental adherence problems. So retained placenta is the baby's been born, the placenta has been born, but it has broken apart, and so there are still pieces of placenta in the uterus. This can cause excessive bleeding, and the physician will need to go in manually, vaginally, and scrape and pull the rest of those placental parts out. Okay, so that's an issue. Cervical or vaginal lacerations, bright red bleeding. You'll see this. You have a firm contracted uterus. You don't feel that bleeding is coming from the uterus. Because of that, you feel that it's coming from some sort of vaginal or cervical laceration. Now, when they do episiotomies and lacerations, of course, the physicians will repair those at delivery. However, you know, if it's a deep vaginal or even a cervical laceration, they may not notice that and may finish what repair they're doing and go on and leave, and you still have bleeding issues, so then you need to call your doc back. But anyways, women who have had forceps deliveries or vacuum deliveries are at increased risk for these type of lacerations. And then, of course, any big baby, a macrosomy baby, they're at increased risk for more severe cervical or vaginal lacerations. Now, placental adherence, let's talk about that a little bit. There's three different kinds: placenta accreta, placenta increta, and placenta percreta. Yeah, why? Well, because it affects the myometrium differently with each one of these. So a placenta accreta is when the placenta is attached directly to the myometrium, okay? This causes the woman to bleed because the placenta does not want to separate after birth. So the physician needs to go in and manually remove that. So a placenta increta is the placenta has attached into the myometrium, okay? So this is at a deeper level, okay? And the placenta is going to need to be surgically removed. This is not just an easy fix here. And then a placenta percreta is it has penetrated through the myometrium, and God forbid if it is attached to the bladder or the bowel or things like that. So women with these accretas have a high instance of abdominal hysterectomy and huge bleeding issues. Okay, and that's all for my recorded lecture. If you have any additional questions, please let me know.